When daptomycin fails, how I approach daptomycin-resistant Enterococcus faecium. What do you do when you have VRE bacteremia, and now even daptomycin doesn't work? This is becoming one of the more difficult antimicrobial resistance scenarios we encounter, particularly in transplant patients, patients with hematologic malignancies, and patients with prolonged hospitalizations. And I want to walk you through a very practical article published in Contagion. When daptomycin fails, practical approaches to resistant Enterococcus faecium. The case is a perfect way to understand the problem. A liver transplant recipient requires reoperation because of a biliary leak. He develops bacteremia caused by Enterococcus faecium resistant to both ampicillin and vancomycin. So essentially, we are dealing with VRE faecium. He receives prolonged high-dose daptomycin along with abdominal washout and placement of a biliary stent. Antibiotics are eventually stopped. And then, only 3 weeks later, he comes back septic. Blood cultures again grow VRE faecium, but now there is a major problem. The organism has become resistant to daptomycin. The isolate remains susceptible to linezolid, tigecycline, and eravacycline. So now the question becomes, what do we do when one of our most important drugs against VRE no longer works? First, why is daptomycin so important for VRE? Enterococcus faecium has become an incredibly difficult organism therapeutically. Resistance to ampicillin is extremely common. Resistance to vancomycin is also extremely common. According to this review, more than 90% of E. faecium isolates may be resistant to ampicillin, and approximately 83% resistant to vancomycin in the cited epidemiologic data. That leaves us with a relatively limited number of reliable options. Daptomycin has therefore become one of the drugs we frequently reach for in serious VRE infections, because it is bactericidal and generally well tolerated. And although daptomycin is not FDA approved specifically for VRE faecium, it is widely used in clinical practice. An important point here: dose matters. For serious VRE infection, we are not talking about 6 milligrams per kilogram. The article emphasizes that doses of 10 milligrams per kilogram or higher have been associated with lower mortality compared with lower-dose daptomycin. That is something I think every clinician treating VRE bacteremia needs to remember. So how common is daptomycin-resistant Enterococcus faecium? Overall, it is still relatively uncommon, but that changes dramatically when you look at high-risk populations. In patients with hematologic malignancies and in liver transplant recipients, the article reports that up to approximately 35% of VRE faecium infections may demonstrate daptomycin resistance. That is a completely different epidemiologic environment, and prior daptomycin exposure is one of the strongest risk factors. In fact, prior exposure has been associated with as much as a 30-fold increase in the odds of daptomycin resistance. But here's an important nuance. Resistance does not require previous daptomycin exposure. Daptomycin-resistant organisms can arise de novo, and susceptible and resistant subpopulations can coexist. Why does daptomycin resistance develop? This gets biologically interesting. Daptomycin works by interacting with the bacterial cell membrane. Resistance can develop through mutations that alter cell membrane charge and phospholipid metabolism. The practical consequence is reduced daptomycin binding to the bacterial membrane. Think about it this way. The organism essentially remodels the surface that daptomycin needs to interact with. But resistance doesn't develop in a vacuum. There are several clinical conditions that create the perfect environment for resistance: high bacterial burden, suboptimal daptomycin dosing, prolonged exposure, persistent bacteremia, deep-seated infection, biofilm, and probably most importantly, inadequate source control. That last one is critical, because sometimes when we say the antibiotic failed, what actually failed was our ability to eliminate the source. Who should make you particularly nervous? There are several populations where I would have a much higher index of suspicion. solid organ transplant recipients, especially liver transplant recipients, patients with hematologic malignancy, bone marrow transplant recipients, critically ill patients, patients receiving prolonged broad-spectrum antibiotics, patients with indwelling devices, patients with disrupted mucosal barriers, and patients with complicated intra-abdominal or biliary disease. Why are liver transplant patients particularly vulnerable? Because these patients frequently have intestinal and biliary manipulation, altered gut microbiology, prolonged antimicrobial exposure, and sometimes postoperative complications requiring reintervention. Anastomotic leaks and biliary leaks are particularly important. In the case presented in this article, the patient had almost the perfect storm: liver transplantation, reoperation, biliary leak, prolonged hospitalization, previous daptomycin exposure, and eventually a deep perihepatic abscess. Now let's talk about the MIC. This is where things can become confusing. If your patient is clinically deteriorating, if the blood cultures remain positive, or if you see the daptomycin MIC increasing during therapy, repeat susceptibility testing. Do not simply assume that the original susceptibility result still applies. If resistance is suspected, confirmation using an alternative testing method may be important, because daptomycin MIC testing can vary depending on the platform. The reference method is broth microdilution using calcium-supplemented media. Why calcium? Because daptomycin's activity is calcium-dependent. The CLSI breakpoint is also unusual. For E. faecium, an MIC of 4 micrograms per milliliter or lower is categorized as susceptible dose-dependent. An MIC of 8 micrograms per milliliter or higher is considered resistant. And there is an important warning zone around MICs of 3 to 4. Patients with organisms in that range appear to have an increased risk of microbiologic failure. But I really like one sentence in this article: clinical failure may be more important than the MIC itself. And I agree. If your supposedly susceptible organism continues growing from blood culture while the patient is deteriorating on adequate daptomycin therapy, the patient is telling you something. Do not let one laboratory number reassure you too much. So now we have daptomycin-resistant VRE bacteremia. What do? The first intervention is not another antibiotic. It is source control. I cannot emphasize this enough. In the case described in the article, repeat imaging revealed a new perihepatic liver abscess. The abscess was drained. Central lines were removed. Those interventions may be just as important as changing antimicrobial therapy. If there is an infected catheter, remove it. If there is an undrained abscess, drain it. If there is an infected prosthetic device and removal is feasible, deal with the device. If there is biliary obstruction or leakage, address it. You cannot pharmacologically sterilize anatomy that continuously recedes the bloodstream. What is the first drug I would think about? Linezolid is the only antimicrobial specifically FDA approved for VRE faecium infection and is considered the drug of choice in this review for daptomycin-resistant VRE bacteremia. And linezolid has a major advantage. It achieves excellent systemic exposure and has extensive clinical experience. But there is a problem. If you need prolonged treatment, linezolid toxicity becomes very relevant. We worry about thrombocytopenia and other myelosuppression, lactic acidosis, peripheral neuropathy, optic neuropathy, and drug-drug interactions. So linezolid may be excellent for 2 weeks, but much harder to tolerate when your patient needs 4, 6, or 8 weeks of treatment. And that is exactly what happened in this case. The patient initially received linezolid along with piperacillin tazobactam because the abscess was polymicrobial. But after approximately 2 weeks, he developed progressive thrombocytopenia, so they had to change therapy. What about combining daptomycin with a beta-lactam? This is one of the most interesting strategies. Even though E. faecium may itself be resistant to the beta-lactam, certain beta-lactams can alter bacterial cell surface charge. That can increase daptomycin binding. So the beta-lactam is not necessarily being used because it is independently killing the organism. It may be acting as a daptomycin potentiator. This approach may be considered when the isolate still has a susceptible dose-dependent daptomycin MIC, particularly around 3 to 4 micrograms per milliliter, or when there is partial susceptibility. Situations where combination therapy becomes especially attractive include persistent bacteremia, endocarditis, high bacterial burden, and incomplete source control. In vitro, several beta-lactams have demonstrated synergy with daptomycin, including ampicillin, cefepime, ertapenem, and ceftaroline. But the review makes one particularly interesting point. Among these agents, ceftaroline demonstrated synergy even against daptomycin-resistant strains in the referenced in vitro data. That does not mean that daptomycin plus ceftaroline is proven clinical therapy for every DRE case. The clinical evidence remains limited, but mechanistically, this is a fascinating salvage strategy. What about tigecycline? Tigecycline may be active against the organism, but there is a major limitation. Serum concentrations are low, so tigecycline should not be used as monotherapy for bacteremia. That is particularly important when we are dealing with persistent bloodstream infection. What about eravacycline? This is where the article becomes very interesting. Eravacycline is a newer tetracycline derivative with potent in vitro activity against Enterococcus faecium. In vitro, eravacycline appears more potent against E. faecium than tigecycline or omadacycline. Clinical data are still limited. However, emerging reports cited in the review described cure rates of approximately 50% to 77% in VRE infections, including difficult scenarios involving daptomycin resistance, refractory infection, and even endovascular disease. Those numbers need to be interpreted carefully because these are not large randomized controlled trials. But when options are disappearing, eravacycline becomes very interesting. And remember our patient? Once thrombocytopenia developed on linezolid, the clinicians transitioned him to eravacycline. What about omadacycline? Omadacycline also has in vitro activity against E. faecium. The article notes that omadacycline and tigecycline have roughly similar in vitro activity against E. faecium, while eravacycline appears more potent. But clinical data for omadacycline in serious DRE bacteremia remain very limited. So, this is not currently a drug where we have robust evidence for routine treatment of DRE bloodstream infection. And what about the long-acting lipoglycopeptides? This is another fascinating area. Among this class, the article specifically highlights oritavancin as having in vitro activity against daptomycin-resistant E. faecium. Could long-acting agents eventually become useful in selected patients requiring prolonged therapy? Possibly, but the evidence is still limited. So this remains much more of a salvage or investigational strategy than standard therapy. Should we routinely use combination therapy? No. The evidence is simply not strong enough to recommend combination therapy routinely for every DRE infection. Data involving linezolid combined with gentamicin, rifampin, or doxycycline have been contradictory. Evidence supporting tigecycline or eravacycline containing combinations is also limited. But there are situations where I would absolutely think about combination therapy. Persistent bacteremia, endocarditis, a very high bacterial burden, deep infection, a retained infected device, or inadequate source control. In those situations, the question changes from what is the standard drug to what combination gives this patient the best chance of clearing an infection with almost no conventional options. And finally, prevention. This may actually be the most important part. If we want fewer daptomycin-resistant enterococci, we need better antimicrobial stewardship. Avoid prolonged daptomycin therapy when it is not necessary. And perhaps even more importantly, do not underdose daptomycin for serious VRE infection. The review specifically emphasizes avoiding prolonged subtherapeutic dosing below approximately 10 milligrams per kilogram when treating serious VRE infections. If you have persistent bacteremia, don't simply continue the same regimen indefinitely. Repeat cultures. Reassess the MIC. Look for endocarditis. Look for an abscess. Look at every catheter. Look for infected hardware. And involve infectious diseases early. Hospitals with large transplant, oncology, and bone marrow transplant populations may also want to monitor their local daptomycin MIC trends over time. My take: daptomycin-resistant Enterococcus faecium is one of those infections that exposes the limits of modern antimicrobial therapy. We have drugs, but we do not have many great drugs. When daptomycin fails, linezolid remains the most established option if the isolate is susceptible and the patient can tolerate it. But in a patient with persistent infection, you cannot separate antimicrobial selection from source control. Drain the abscess, remove the infected catheter, address the infected device, and then individualize therapy. For selected patients, that may involve high-dose daptomycin plus a beta-lactam when some daptomycin activity remains. It may involve eravacycline when linezolid cannot be continued, and occasionally it may require much more creative salvage strategies. The future may include newer tetracyclines, long-acting lipoglycopeptides, combination regimens, and perhaps even phage therapy. But right now, the evidence remains limited, and the optimal treatment of daptomycin-resistant ephesium is still not clearly defined. So if there is one thing I want you to remember, it is this: when daptomycin fails, don't just change the antibiotic. Reassess the organism, reassess the MIC, and most importantly, reassess the source. Because sometimes the most powerful antimicrobial intervention is a drain.